Okay. So now, what do we do about this? So maybe you or somebody you love is hypermobile. What are we going to do about it? So again, this is me. I don't think we have any new people here. I still don't have any conflicts of interest. Same thing about the zebra. And a group of zebras is a dazzle. So you guys have a lovely and we have a dazzle. So, and the same lecture series and handouts. And this, so this is where I've been saying that there are handouts on headaches and things like that. That's at that web page. And once you get to one of my web pages, you'll get to, yes. Pardon? If you go to any of my web pages, you can get to all the other ones. Yep. Once you get there. Yeah. So, for example, surgical precautions, why you're not the same in the hospital, hypermobility in children and adolescents, the graphic that I showed of all the different symptoms, the woman's figure with all the different symptoms, all of those are available. My usual disclaimer. Okay, so now session 2, we're going to talk about ways to minimize the symptoms of hypermobility. Because we can't make you not be hypermobile. Where to get some additional resources and a few things on the bleeding. So again, these are the different areas that might be affected. So how do you figure out where to begin if somebody's got, 20 different things going on? So I might try to look for the causative factors. So you heard me say a couple of times that mast cell activation might be driving some of the instability, might be driving some of the POTS, might be aggravating some of the bleeding. Well, if that's the case, try managing the mast cell activation. If you have cervical instability and it's driving your headaches and neurological issues, then work on that. So if you can ever identify something that's causing a bunch of other problems, that's a worthwhile place to focus. Or, of course, the most problematic area. So if you have so much cervical instability that you can't stand or sit up, that's problematic. So you might start there. And then sometimes low-hanging fruit, like let's work on your breathing, because that's super easy. You can do it anywhere, and it doesn't cost you anything, right? So I call that low-hanging fruit. Calm your nervous system down. We can always do that. Almost never makes anybody worse. So there are different ways you can choose where to begin managing. You can use that spider tool that we talked about, where you might say, it's like, okay, fatigue's my worst problem. Let's work on that. Because I can't give a patient exercises if they're too tired to get up off the couch, right? It's just going to make them feel bad to say, well, I want you to do 20 minutes of exercise every day. So depending on what's going on. Okay, so this is a condensed version. As you saw from my lecture series, I already have 16 hours of how to manage hypermobility, so we're not going to get through all of that. My overall approach, it has 3 phases where you should start. So a foundational phase, progressing, and then as we move on. And when I've seen, so I'm an EDS specialist, when I see people who have failed PT before, it's usually because they've started up here, that the PT said, oh, you're hypermobile, let's get you strengthening. Oh, you're tired, let's get you working on your endurance. Well, those things are going to make you worse if you have an unstable, exhausted, traumatized body to begin with. So we need to stabilize your system, pun intended. So on the bottom right, basic things that everybody does every day. You have a posture. You are always in a posture, whether you're sitting, standing, or lying down. And that posture could be stressing your body. If you're hypermobile, you can dislocate a joint while you are sleeping, right? And so you want to learn good posture. Joint protection. How can you position your joints, use your joints so that you're using them wisely and safely and not stressing them? When can you use assistive technology to help decrease the stress on your body? Breathing correctly, and then how you walk, because most of us walk and it's something you do over and over. So things that you do over and over again, if those are stressful to your body, it is going to be cumulative, okay? Pain management, obviously, if you're in a lot of pain, we're not going to be able to get you doing exercises. But also, if your nervous system is sensitive, everything is likely to make you worse. And a lot of my patients will say, well, I went to PT, but it made me worse. I tried exercising, but it made me worse. They tried doing manual therapy, but it made me worse. Well, they probably had a hypersensitive nervous system. If your nervous system is sensitive, we need to calm it down first, right? And then recognizing and managing comorbidities. So fatigue, POTS, mast cell, GI problems, bleeding, that there are a lot of reasons why their health is unstable, okay? Once those things are under control, sort of at least, I mean, we don't get complete control over it, but once you've got a handle on it, then I can add in movement. So proprioceptive or body awareness training, interoception, which is your internal sense of being. Am I tired or hungry or thirsty? Turns out that's not working properly in people who are hypermobile, and that leads to issues. How your brain integrates sensory information and how you control the muscles. Because if you can't control your muscles, we can't exercise safely. Then we can progress to the top level, where we're integrating things back into your normal functional activities. We might get you doing normal exercises. And of course, if you're hypermobile, you're likely to have flares, and you kind of move up and down the system. And then on the left, you see self-care, right? Because hypermobility is something you have for your whole life. And so you want to learn how to take care of it as much as possible, so you're not reliant on going to a PT every time something flares up, that you have a toolbox of things you can do yourself. And we'll talk about toolboxes before the end of today. So we're going to start by talking about that foundation level. And again, this is going to be the super quick view, but I'm going to point you to handouts and lectures where you can get more information if you want more. So breathing correctly. We'll talk a little bit more about that. Posture, braces, pain management. Let me just make sure. Yes. So we'll come back to some of those things with some of the sort of key approaches. Pain management, including a sensitive nervous system. So there are 3 types of pain: nociceptive, neuropathic, and nociplastic. I did not name them. I'm sorry about that. The first 2 can fall into what I call issues with your tissues. So either mechanical issues or inflammation. The third one is what we used to call central sensitization. Your central nervous system was sensitive, and I call that volume control. That's like somebody just cranked up the amp at a rock concert and is just screaming, okay? If you have problems with that volume control, you need a completely different way to manage pain than if you have mechanical issues or inflammation in your tissues, okay? So figuring out which of those you have is critical to being successful in treating it. An analogy that I'll sometimes use is, if your car won't move, you can put gas in it, but it still won't move if you have a flat tire, right? You need to address both of those if you want it to move, okay? So addressing the issues with the tissues and volume control separately. In volume control, you need to calm the nervous system down, so things like breathing, relaxation. These things can actually decrease the inflammation in your nervous system. So for pain management, there are lots of different options. And again, things in purple, I have a handout on if you want to look up more. So we have classic physical therapy pain management like ice and heat. That's great. Topicals, things like Icy Hot and BioFreeze and Arthra Cream can be helpful as well. A TENS machine, so transcutaneous electroneural stimulation, or called an electromassager, can be helpful. I love having one of those in the toolbox. As a matter of fact, that's how I survive airplane rides. Trigger point, we were talking about trigger points before, learning how to recognize your trigger points and learning what to do about them. There's lots that you can do yourself. Having supports or braces or taping or splints. So, I've got splints on a couple of my fingers so that I can function. Calming your nervous system down. Cognitive behavioral therapy so that your brain's not going haywire. Pain education, learning about pain. Research shows that if you understand how pain works, that it's not so scary. And when you're less scared of it, you won't have as much of it. Medication, of course, although I'm not a big fan of treating symptoms if you haven't figured out the cause yet. Decreasing inflammation, aerobic exercise or specific exercise. So all of these could be helpful for managing pain. You need to figure out what's appropriate for the pain, the reasons why you might have pain. For sensitivity, so I like the image of a sensitivity bucket, right? That the more full the bucket is, the more sensitive your nervous system is, okay? Things that fill the bucket, obviously tissue injury and stress, inflammation, and that includes mast cell activation. Dysautonomia and POTS also makes the nervous system more sensitive. Poor sleep and poor diet. A sedentary lifestyle, stress, anxiety, fear, negative thinking, social stressors, economic stressors, and challenges of the healthcare system. And the reason why I find this model helpful is that there's some of these things you can't easily change, right? So economic stressors, the healthcare system, we're not going to change those very quickly. However, you could work on getting a better night's sleep and having an anti-inflammatory diet. So anything that you can change to decrease how sensitive the nervous system gets, or at the bottom, pretty much everything in reverse, the more things you can do to help calm the nervous system down can all be beneficial. So you don't have to get stressed out that you can't fix everything if there are some things you can change. And realizing that each of these might only improve your pain by 5 or 10%, but if you can find 5 things that are 10% improvements, that's a 50% improvement, and that's worth it. Just don't expect miracles that, well, I'm going to get 8 hours of sleep and tomorrow I'm going to feel good. It's like, well, it might take a little more than that, okay? But the sensitivity bucket, think of it in that way, that all the things you can do to decrease that bucket. So we're going to come back, talk a little bit about the posture and joint protection. So why are posture and joint protection important? Well, you want to minimize the stress to your body. If your connective tissue is fragile, you don't want to be putting excessive strain on it. You don't want to overuse it. That every time you take a step, it's not a lot of stress on your body, but if you're doing 10,000 of those a day, that accumulates, okay? You don't want to overstress the muscles, so that you don't want them to go into spasm. Poor alignment can also compress blood vessels and nerves, which can interfere with their function. Of course, you can have accidents, twist your ankle or dislocate things, but also improve the quality of your movement and your function. So protecting your joints. How do you protect your joints? So using bigger, stronger joints when possible, using 2 hands rather than 1. Obviously, this will depend on what your body is like. That if you have 1 bad shoulder, using 2 arms might not be better than using your good arm, right? You want to minimize the amount of force on the joints, or minimize how repetitive it is. Avoid carrying heavy things that pull the joints apart, distract the joints. You want to try to keep your body in mid-range and aligned, using the proper tool for the job. So if there's something that needs to be lifted, don't just go lift it and damage yourself, but, go get it, one of the rolling carts. Keep your muscles strong. Avoid staying in one position for too long, even good alignment if you're there for an hour or 2 hours. And then use splints and braces if that's helpful. These are some examples of some body mechanics. So we call this hinge hip. If you imagine holding a broomstick along your back so that it touches the back of your head, your upper back, and your tailbone, you want to keep those 3 points in alignment on your spine as you're, let's say, leaning forward. and that will protect your spine. You don't want to be bending forward at the waist or having your head bend upwards. And this can be helpful even in things like brushing your teeth. So rather than brushing your teeth like that, saying, okay, I'm going to use this hinge hip. So this is an example of how you can protect your body. Using splints and assistive devices, especially for hands, there aren't a lot of muscles in the hand that can protect. So we do a lot of forceful things with our hands, and so it can be helpful to use devices. So a jar opener. The fingers up here, thumbs should not bend that way. And so there are finger splints that can help keep your joints from bending in the wrong direction. Fingers should not scrunch up like that when they're holding a pen or a pencil. And there are devices that can be used to, make it easier to hold a pen or pencil, especially for kids, because you're not going to tell a 5-year-old, don't squeeze on that pen. They're worried about, writing their name. Yeah. And a lot of these can be cheap home gum and tape fixes. Braces and splints can be helpful, especially if they allow the joints to move. So the knee braces in the middle, she probably had knees that were knock-kneed, and knees are not supposed to bend in that direction. But a brace like this can help to prevent that and allow her to bend her knees where they're supposed to, so she can be more active. Doctors tend to disparage braces and say, oh, you shouldn't wear a brace. It's going to make you weak because you're not going to use your muscles. And that can be true if you're wearing a brace that prevents you from moving a joint entirely because you're not using the muscles to move it. But a lot of these braces allow movement. They just control the movement so that it goes where it's supposed to go and doesn't go where it's not supposed to go. And some of them, like the sacroiliac brace, there is no muscle that's going to get weak because you're wearing a sacroiliac brace, okay? So lots of things are available. Whatever joints are bothering you, there's probably a device that can be helpful. And I have a whole handout of those as well. Functional supports, these are things that are definitely allowing us to move around. The picture of the orthotics. So if you have really flat feet, that is going to propagate problems all the way up, potentially up to your jawbones. And so sometimes just putting a shoe insert so that you're lined up can help to stack you up more efficiently. And I've had a number of patients where just putting a shoe insert in fixed some of their problems. That's low-hanging fruit. Okay, a posture support brace, because it takes energy to have good posture, and your muscles might not be strong enough to do that for 8 hours a day. And, if after 6 hours you're starting to slump, like some of us in here are doing, that's going to put stress on your body, right? So maybe a posture shirt can help you do that. Hip, shoulder, toe, all sorts of supports. Compression. So compression is particularly important for POTS, if you have POTS, because it prevents blood from pooling in your legs. But it turns out that compression clothing also helps to improve our body awareness, our proprioception. So if you remember last lecture, I talked about how the nerve endings in your joints don't function quite right because your joints are too stretchy. So people with hypermobility have poor proprioception or body awareness. We don't know where we are. We kind of tend to be clumsy. And compression clothing can allow your skin nerve endings to help supplement your joint nerve endings. And so there's some really good research that shows that a compression shirt can help decrease shoulder pain in somebody who has shoulder instability when they're exercising. It only works when you have it on because it's that skin contact. So some of those braces, like there's a little elastic sleeve over the ankle. It's probably not physically supporting the ankle, but just the skin contact might help the awareness of where it is and prevent ankle sprains. Okay. Breathing. So why breathing is important. This is one of those low-hanging fruits. If you only do one thing to manage pain, I would say do good breathing. Okay, why? So good breathing is that you're breathing slowly, so you're not breathing too many times per minute. It shouldn't be more than 8 breaths per minute. It should be diaphragmatic, so belly breathing, and we'll talk about that in a minute, and it should be through your nose, not through your mouth. If you don't do those things, you may have neck pain, headaches, arm pain, swelling in your arms, numbness in your arms, problems swallowing, sleep problems, asthma, shortness of breath, low back pain, and instability and sacroiliac instability. Turns out that the diaphragm that we breathe with helps to provide lumbar stabilization. And so if you're not breathing correctly, your back may be unstable. It improves your heart function, or rather bad breathing poorly will impair your heart function, impair lymphatic fluid movement, and contribute to anxiety and headaches. Okay, so lots of problems that can be aggravated by breathing. So what's good breathing? So I used to teach what we call belly breathing, which was breathing in and out through your belly. Okay, not bad. It's better than chest breathing. Okay, but now we recommend what we call umbrella breathing, where we say your ribs should be opening up kind of like an umbrella. So if you put your hands on your lower ribs and you take a breath in, they should feel like they're expanding like an umbrella in all directions, and your chest should not be moving up and down. Because none of you are exercising. If you're not exercising, you shouldn't be using your neck muscles or your upper chest to breathe. Okay? Like I say, low-hanging fruit, something easy to work on and can have a lot of benefits. Okay, we'll talk a little bit now about proprioceptive, interoceptive training, sensory integration, and motor control. Okay, so exercise is key to managing hypermobility, the musculoskeletal aspects, but it has to be the correct exercise done correctly. And if you take people who have poor body awareness and they don't have good motor control, so they tend to go from 0 to 100, and you just say, well, do these exercises, it's not going to go well. Okay. So you have to develop the proprioception first, the body awareness. That may involve getting feedback. So I'll put a laser on somebody's head so that they know that their head is wobbling around and teach them how to wobble less. I might put we call it pressure biofeedback. It's kind of like a blood pressure cuff underneath their back or their neck, and teach them to feel whether they're moving or not. So learning body awareness. Sometimes you can't just think about it. Sometimes you need some input to learn it. In general, you want to do slow, controlled, and precise movements. So you don't want to be doing 3 sets of 10 of things that most PTs will give out, but you want to do maybe 5 repetitions slowly, done well, without joints slipping out of alignment. Okay, so how you do the exercises are really important. Compression clothing, kinesio tape, braces can also help with your body awareness, as I just talked about, and the external feedback, the laser, the biofeedback, and making sure you're learning how to use the correct muscle. So when I'm teaching a person to do an exercise, I'll say, okay, I want you to contract on a scale of 0 to 10. 0 is you're completely relaxed. 10 is contracting as much as you can. I want you to try to do like a 1 or a 2 out of 10. Nothing's going to move. Only you are going to feel anything happening. I want you to try to feel that 1 out of 10. Good. Because when you're doing those low intensity muscle contractions, you're going to use the deep stabilizing muscles. When you do power movements, you use superficial muscles that destabilize. Okay, so more is not better. Doing slow, controlled movements. So let's talk now a little bit about self-care. So learning things that you can do for yourself. So you're here, you're learning about hypermobility. If you think you might have POTS, learning more about that. There are a lot of self-care things you can do, and there's a whole exercise program that you can do to help recover from POTS, to retrain your nervous system. MCAS, there are a lot of things, lifestyle things that you can do for that. And again, everything in purple, I've got a handout on my website if you want to learn more. If you've gotten to the limit of what you can change in your body, start thinking about what accommodations you might need, what assistive technology might be helpful to you so you can be more functional. And there's a lot of recommendations out there, obviously, for people who bleed, learning about that. GI problems, gastrointestinal problems, jaw problems, headaches, fatigue. Sleep is super important. I don't call that low-hanging fruit because it's much harder to fix than breathing. You can think about your breathing and change how you breathe. You can't just think about sleep. But sleep is critical for your body to heal and for your nervous system to flush out all the toxins that contribute to pain. I have a self-care toolbox on my website. It's got a checklist of different things that might be helpful for managing symptoms. It's organized by physical things, devices you can use, calming your nervous system, general wellness, exercise, managing your POTS, medications, and then across the top, what symptoms it might be helpful for: pain, instability, fatigue, inflammation, etc. And you might circle the strategies that work for you so that when you have a flare, you know what works for you. But something like this can help you to think, it's like, oh, I haven't tried topicals. You know, those rub-on things, that might be helpful. And sometimes they really are helpful. And to create a physical box of a toolbox. So I actually have a physical box where I keep all the braces that I sometimes need. So I've got like 4 different wrist braces depending on how bad my wrist is. And I've got 5 different finger splints depending on which finger is going bad, and sacroiliac belt. And, when I'm having a flare, I pick out the thing I need to use. I've got my TENS machine, which is on every airplane with me. But whatever it is that helps you take care of yourself, put it in a box somewhere, because people tend to forget they have it. I'd have patients come in saying, oh, an awful weekend. I had this terrible flare. I'm like, did you use your TENS machine? They're like, I didn't even think to. It's like, that's why you got it. And it works better when you use it. So a checklist like this can be helpful. And a flare management plan can be helpful as well, because when you flare up, you don't tend to be thinking clearly, right? It's like, oh my God, things are awful. And having it written down of what's my go-to when I have a flare, that can be helpful as well. You can print that from my website as well. So we're going to turn now to some things related to bleeding. And I'm not sure I'm going to have anything new to tell you here. We'll see. So surgical precautions. We talked about this a bit in the last hour, but orthopedic surgeries are only half as successful in hypermobile people. So think longer and harder before you agree to have them. The risks of complications are much higher. So again, think long and hard before you decide to go for it. What might be a simple surgery for another person is never simple if you have hypermobility. And if you have a bleeding disorder, it's going to be even more complicated. Okay. Tissue healing is slowed. So not just skin tissue, but whatever they're fixing, it's a hernia, everything is going to be slower to heal. They need to do special kinds of sutures that are closer together, left in, done in several layers, etc. Make sure that your doctor knows about that. And I have it's like an 8-page handout on surgical precautions of things that you want to be aware of if you're going to have surgery or if you're going into the hospital for something. And there's actually a really nice handout, not my handout, but by Chronic Pain Association, and on how to prepare for surgery if you're hypermobile, things that you can plan for in advance. So prophylactic treatment for bleeding. So recognizing that the person has a bleeding disorder, not so important for you guys because you guys know that. But for my patients, they often don't know that, and their doctors don't know that. So they go in and have a surgical procedure or have a baby and have a massive bleeding crisis. Maybe avoiding contact sports or things that are likely to cause bleeding, more prophylactic care, avoiding tourniquets, preparation during childbirth. And somebody earlier had asked me about childbirth issues. So the Pizarro 2024 article is an awesome compilation of guidelines of pregnancy, childbirth, and postpartum issues for hypermobility, POTS, and mast cells. So it's a really awesome article for people who are hypermobile. And then maybe vitamin C supplementation. We think that may be helpful with the mast cell activation. You guys know this. Avoid things that are going to thin your blood. So medications, but also some of the supplements that might affect you. So management of bleeding in hypermobility, there's not research on what's best practice yet. So this is just what is happening. And it's the same medications that we've been hearing about today. So people who are hypermobile with bleeding problems can be treated in similar ways as people with bleeding problems. So that's good to know. Menstrual bleeding, again, the same options of hormonal treatment that you heard about today is also applicable for patients with hypermobility, with one addition of management of the mast cell activation. So remember I said mast cell activation can cause engorgement of the vascular tissues in the uterus. So managing the mast cell activation may also help to decrease bleeding if you have mast cell activation. Okay. So in summary, there's no cure for hypermobility, but there are a lot of things that can be done to decrease the symptoms, improve your function and quality of life, starting with a foundation so that you've literally stabilized your whole system before you start adding in exercises is really important. Managing the mast cell activation is important for, particularly important related to bleeding. And there is, like I said, very little research into what to do about the bleeding in hypermobility. Hopefully in the next 5 years, we'll have more of that. We're just recognizing that it's there. Resources. So again, you can get to my website using that scan code. The Bendy Bodies podcast. That's one of the really excellent hypermobility physicians who interviews specialists. If you think you have mast cell activation, TMS for a Cure has excellent information as well. Everybody who wants to scan that got that. It's the same scan code I've been showing to you, but they get you to my website. And then lots of references, and then time for questions.
I forgot about that. I had a question about vitamin C. So, as we've talked about, my daughter has EDS and all the things, and her doctor tested her vitamin C levels because she started doing that with her EDS patients. And my daughter had scurvy; she had like clinical scurvy. Like they actually had to run the test through LabCorp a couple times because they hadn't seen it before. And so now I'm curious about that because she's also got low ferritin levels and everything, like vitamin C and iron. So is anyone doing any research that you know of, or is anyone like doing this on a clinical level where they're taking EDS patients, especially those with low iron and ferritin, and seeing what their vitamin C levels are to see if like supplementation. So she started doing vitamin C IVs, which did start to help, but supplementation was hardly touching it. So I'm just not hearing anybody talk about that. So I'm curious.
No, to my knowledge, that's a great question. And it would be not very difficult research to do to just look to see what deficiencies are there and what symptoms those people have and whether there are patterns to that. Yeah, after this morning's lectures with the iron deficiency, because iron deficiency symptoms looks a lot like POTS. And so now I'm thinking it's like, well, everybody with POTS ought to get tested for iron deficiency because that's low hanging fruit, right? That's easy to fix. And so, no, that's an excellent idea that would be, or at least I'm not aware of it. And I do stay pretty up to date on the research, but you're absolutely right to look at what deficiencies are there and then what symptoms are those people reporting. But it is interesting to see that her levels of vitamin C were even off the normal, because most of the times, like you guys have been talking about, you're in the normal range, but it's not enough for you, but sometimes it's just plain not normal. No, that's great. There are some, if you want to learn more about supplements and the recommendation for supplements, there's an excellent article on pain management in hypermobility where they have a whole lifestyle approach of manage the sleep and the stress and the diet. And they have supplements as a category in there where they recommend certain supplements. So if you're interested in that, that's probably the most information on supplements in one place that I'm familiar with. Right. Right, right. And so vitamin C affects bleeding. It also affects bleeding via the mast cells. So vitamin C is a mast cell stabilizer, right? So you stabilize those mast cells, they're not releasing heparin. So it could be all of it, yeah. And again, that's low-hanging fruit, right? That taking vitamin C is not that hard compared to some of the other things people have to do. Yeah, and so there are probably multiple mechanisms by which it's working. And many of the physicians who treat mast cell activation, one of the first things they'll do is say, take vitamin C. And then there are a couple of other supplement stabilizers, quercetin, that they recommend. And again, it's kind of low-hanging fruit. It's a pretty easy thing to do, pretty harmless. You're not going to risk doing harm. Yep, great.
Why did you say that orthopedic surgeries are not successful? Is it because of the symptoms that, the things that would, why are you saying that?
So research and multiple research studies, at least 5 that I know of, show that if you ask people, if you do your standard assessments after a surgery, are you able to walk better if you had a knee surgery? Is your arm function better after an arm surgery? That those functional assessments are only make there's a certain point at which you say a surgery was a success, right? If you have right. So whatever the surgery is, it doesn't have the beneficial effect that you were hoping for, right? That you want people after surgery to say that they are moderately to much better than they were before the surgery. And that doesn't happen with people who are hypermobile, that they will say, I'm no better or I'm worse. Okay. So hypermobility is how much motion you have, or hypermobile just means a joint moves too far. Hypermobility is a term that we give to people who have, usually to people who have generalized joint hypermobility. And hypermobility spectrum disorder or hypermobile Ehlers-Danlos syndrome are the syndromes that are associated with symptoms that result from the connective tissue disorder that's causing the joint hypermobility, but also affecting all the other connective tissue in your body, which is why you can have GI problems and neurological problems and bleeding issues. That we call it hypermobility because you can see that, but connective tissue can be affected everywhere in the body. Okay, and so I'm using the term hypermobility to refer to hypermobile Ehlers-Danlos syndrome and hypermobility spectrum disorder, which are the 2 diagnoses which are associated with musculoskeletal pain, bleeding, GI problems, neurological problems, et cetera, et cetera, et cetera. Yep. Yes.
So I have the EDS trifecta, along with long COVID and platelet disorder. And so I started developing dystonia, and I had one neurologist cite an article that said that a lot of people with EDS get dystonia, but then all of my other providers, my PTs, OTs, and PMR that specialize in EDS disagreed, and said that they do not see patients with dystonia that often. So I wanted to see.
Okay, so for people who don't know what dystonia is, it's when a muscle contracts and it's not supposed to, and it might contract and just stay tight, or it can be sort of a phasic dystonia where muscles are contracting and out of your control. It can be extremely painful because muscles are contracting much more than they're supposed to contract. So the question is it or is it not more common in hypermobility? So it is a bit more common, but it is not one of the most common symptoms in hypermobility. Okay, so of all my 30 years of treating patients with hypermobility, I've probably had 5 that had dystonia. Okay, so it happens, and it can happen for a number of reasons. It's usually associated with a sensory integration problem, so the brain is not putting information together properly to know where you are, and so muscles are being told to contract when they shouldn't be told to contract. It can be extremely painful. It can be rather challenging to treat. Usually, the people who treat it will use sensory retraining, so trying to change the input that the brain is getting of what your body is doing. Biofeedback can be helpful for that, to retrain the nervous system. There's a related condition that's overlaps with dystonia called functional neurological disorder. And it's a disorder where your body is being inconsistent. So it used to be called conversion disorder or hysterical disorder, basically when you might not be able to walk one moment, but then you can walk the next moment, and they think that people are faking. And it's not faking, it's a sensory integration problem where your nervous system is not putting information together properly. And people with functional neurological disorder may have dystonias where their body is doing funky things, and that's because the feedback system in your brain that tells you don't go too much one way or the other. It's kind of like when you're in the car, if you've ever driven on ice and you turn too far, you start skidding, and then you try to turn the other way and you skid. Well, it's your nervous system doing that. Functional neurological disorder, there are some specific treatments for that. And so I often recommend people with dystonia at least consult with somebody who treats functional neurological disorder to see if that sensory integration approach can be helpful. But there are no simple answers. Sorry. Yeah. Yep. Other questions?
Do you see a lot of like neurogenic thoracic outlet syndrome in Ehlers-Danlos patients?
Yes. Yeah, absolutely. So thoracic outlet is the space near your neck where nerves and blood vessels come out of your thoracic cavity and they go into your arm. And it's a very, very common problem. For one thing, the arm is often drooping down because the muscles just don't hold it. And so the nerve ending, so if you imagine holding 20 pounds of groceries in both arms all day long, that's basically your arm on EDS that is just drooping and it's pulling on the nerves. And the muscles in the neck may compress the nerves, especially if you're chest breathing. And so there are a whole bunch of reasons why people with EDS are particularly vulnerable to thoracic outlet syndrome. It can be managed in pretty much the same ways as thoracic outlet syndrome in other people, just making sure you realize that if the muscles are too stretchy, you don't want people just holding their muscles up. So it is very common. Nerve compression disorders in general are common in EDS, and not just the peripheral nerves, but the spinal cord, medulla. So there's some fairly complicated neurological problems that are more common. But it is very treatable, but you have to really be working on all the contributing factors, make sure that there's no tension on the arms, make sure that the muscles in the neck are doing correct jobs that they're supposed to, that there's not too much drooping, that most patients can get better, but they're always vulnerable to it flaring up again. Yeah.
How do you, I guess, determine if that, the thoracic outlet problem is something that you have, or just you've got a pinched muscle or a strained muscle or just something in the shoulder? Because I've often complained about numbness in my arm, the drooping of the shoulder, whether or not it's been in place, but I've also had multiple torn rotator cuffs. I've had issues like that. And I've also had doctors, say, get off social media. It's not, stop searching for problems as opposed to actually having a problem.
If you have pain and symptoms, you have pain and symptoms. Okay. So reading social media is not going to make your hand go numb. Okay. Right. It can I will have an exception. So remember, we talked a little bit about the sensitive nervous system. If you read social media and you feel like, the world is in crisis, then your nervous system is on high alert and the volume's cranked up. Okay. But when the volume's cranked up, there had to be something to crank up. So there's got to be something going on there. Okay. So it may be more painful if you're stressed and anxious, but there's still something going on. So how do you tell one problem from another? And that's where physical therapy, I think, is really helpful, that I can stretch your nerve without stretching your muscle, and I can stretch the muscle without stretching the nerve, and I see what provokes the problem, right? So if you have thoracic outlet and I put your nerve in a stretched position, it should reproduce your nerve problems, okay? If you have spasm in your neck muscle and I stretch your nerve, shouldn't reproduce your problems. If I stretch your neck muscles and it reproduces your problem, it's a neck problem, although it may refer into your arm. You could also have a problem in the cervical spine, a pinched nerve in the spine. So there are physical examination tests that can differentiate between all of those, and a good orthopedic physical therapist will be able to say, well, if this test is positive and that test is negative, then at least with a high likelihood you have this problem. Now, you could also have a couple of things. So if you have an unstable shoulder, you are more likely to have thoracic outlet because your shoulder is drooping, so you may have both, right? But it can be complicated to figure it out. And sometimes with patients, I might say, okay, you've got some shoulder instability. Let's do something about that. Okay, I'm feeling like that's getting better, but you still got the numbness. Okay, then you probably have something else going on. Let's work on that. So sometimes it's like an onion. You have to do one layer at a time, that you fix one problem and then you see what's left, and then you fix the next problem and you see what's left. It's not always an easy to figure out. Yeah, great question.
How do you find a physical therapist that is going to do those things and not jump straight to the strength of your part?
How do you find a good physical therapist? So the Ehlers-Danlos Society has a list of providers, a healthcare directory. Doesn't guarantee that they're good, but my theory is, why would somebody bother putting their name up there if they at least don't care about EDS? And nobody goes into treating EDS if they're not willing to take the extra effort, right? So that's one way to find it. If you can find any EDS provider, a nurse, a physician, an occupational therapist, they will know the other EDS knowledgeable providers in the area. So I, for example, have a list of everybody within 90 miles. If somebody contacts me and it's like, nutritionist, I'm like, you're going to have to drive 2 hours, but I can tell you who to see, right? And then the third way is support groups. So local support groups, and go on there and say, I'm looking for a PT who's good at shoulder stuff, and they'll tell you who they've found to be good. It can be hard. It takes more time because people with EDS are complicated and they often have multiple things going on. Unfortunately, with our healthcare insurance system, the best PTs don't get reimbursed what they would need to, so a lot of them don't take insurance. And they do that because they just, they can't do an evaluation in 20 minutes. They just can't do it. And that's all insurance will pay them for. So just be prepared for that, for some of the best people to be self-pay, although you can then submit for insurance, but just be aware. Yeah. Yeah. Any other questions? Okay. Yep.
Can you talk a little bit about physical therapy and managing subluxations during physical therapy? I know there are aids and braces and things we can wear, but there are also some movements in physical therapy where it's hard to wear a brace to try and work that area. Mm-hmm. And so personally, I suffer from a ton of subluxations. I always have. And with the bleeding disorder and other things, it causes more issues. So can you talk a little bit more about when you are working with PT and you're getting into a good rhythm finally, and you're learning a little bit more about your body, but you're trying to improve certain things, how to manage subluxations outside of just braces?
Yep. Okay. So let me use low back instability as an example. So if you have low back instability, sometimes little movements can cause it to slip out and can be extremely painful. So I would probably start a patient in a supported position, like lying down, where you've got some support so that you're not likely to be wobbling around. I would have you learn how to stabilize that area without moving it first, because if you activate muscles gently and you're not moving, you will not sublux. We might need to position you in a certain way to realign the joint first if it's sublux to begin with. So if your shoulder's drooping down, I might lie you down and I might reposition the joint so that it's in the correct position before I have you activate any muscles. So we would generally make sure it's in good alignment first, work on activating the muscles without movement first, and particularly those muscles that stabilize the joint. So I have what I call this drawing in maneuvers. So for the hip, it's like I want you to suck it in like you're drawing it in through a straw with an intensity of 2 out of 10. If I see any movement, you're doing too much. Okay. And once you do that for a week or two, then we'll get you doing something more. And that's where I was talking about. You got to start with the stabilizing muscles and low intensity activations. Make sure that's working correctly. And it may take a month before I get somebody to actually move that joint, before they're ready to move it without it destabilizing. Yes. Yep. So align it so it's properly aligned to begin with, or, if you have a rib that's subluxed, it might need to be realigned. Activate the muscles isometrically, that is without motion, at low intensity, and gradually increase the intensity. Then work peripheral muscles or joints that are nearby. So if I'm working on the back and I'm lying on my back, I might let my knee roll out so my back's not moving, so I can maintain stability because I've learned how to do that and I'm not trying to move it. And then gradually, now I can lift up. That's harder. And start low, go slow. And most PTs aren't patient enough for that. Yes. Well, they're going to see the same number of patients no matter how you progress, but they have to prove to the insurance company that you're getting better. After 6 visits, they have to show that it is so slow.
In an area for a while, and it seems like we're not making progress. We are making progress, but it's so incrementally slow that clinically it doesn't make any sense. And I've run into that.
Yeah. And sometimes for that, to show that you're making progress, you need to have the right measurements. So we'll use the a functional assessment scale where I'll say, tell me one thing that you want to be able to do that you can't do now. And you might say, I want to be able to roll over in bed without my back slipping out of alignment. And it's like, okay. In 6 weeks, I think we can get you to roll over in your bed. We're not going to get you out running a marathon, but we can get you to roll over in bed without your back slipping out. And I would measure, it's like, okay, how much of a problem is that now on a scale of 0 to 10? So you have to pick the right goals so that it's something somebody can make progress in. The biofeedback is really helpful for that, because when you put the biofeedback in, so I'm lying on my back and I'm rolling my knee out and I'm watching a gauge, and it's showing that I'm wobbling all over the place. If I can say, well, you're wobbling all over the place now, but in 2 weeks, you're going to be able to do that and hold it still within 2 millimeters of mercury. That way you can show progress. Or I can put the head laser on you and I can say, how many degrees of wobble do you have? So sometimes there are some other measurements that we can use that are finely tuned to show very small amounts of progress. Yeah. Okay.